Hello, today I'm going to discuss about stroke mimics and chameleon. My name is Dr. Ranjan Sanyal. I'm one of the consultant stroke physician in University Hospital of North Midlands, and I'm also the innovation lead for the Kiel University. So, coming on to discussion about the stroke mimics and chameleon, two are exactly obviously opposite. Mimics is something which look like stroke, but it is not stroke, it is something else. Whereas chameleon is exactly the opposite of mimics, where they look like something else other than stroke, but they turned out to be stroke. So we will go into a bit more detail. What do we mean by that? So if we look at the general principle of symptoms in neurological disorder, it can be divided into two main groups: disease presenting with positive symptom and disease presenting predominantly with negative symptom. The positive symptom, where there is excess central nervous system neural electrical discharge, so that's why the symptom might be visual, like flashing light, zigzag line, shapes and object, which is very common in migraine, as you all know. Sensory, like paresthesia and pain. Motor, jerky limb movement, for example in various movement disorders, seizures, etc. And usually migraine and seizures are characterized by having positive symptom. These are the two disorders where mostly symptoms are positive. Whereas there are other group of disorder where the symptom can be negative, loss of or reduction of the central nervous system function. For example, weakness of the limb, paresthesias, loss of vision, loss of hearing, and TIA and stroke typically presents with negative symptom. But remember, although TIA and stroke predominantly present with the negative symptom, there are certain exceptions where TIA and stroke could present with positive symptoms as well. Now, when somebody is presenting with stroke-like symptom, or the probability of having stroke is more if they have got, for example, abnormal eye movement, abnormal or high systolic and diastolic blood pressure, or history of angina and AF, which essentially indicates that they have got either vascular risk factor or the features which are more suggestive of neurovascular event. On the other hand, if there is loss of consciousness, if the eye movements are normal, if there is cognitive dysfunction in general without any focal deficit, younger age group without any vascular risk factor, and last probably least to remember, even female sex, the increased risk of mimics is more. So just to be mindful about that, but these are by no means confirmatory. Stroke mimic, it is important to quickly or rapidly diagnose this patient, because otherwise they receive unnecessary treatment which could potentially be not useful and be harmful as well. And obviously if we diagnose them early, usually if we reach the correct diagnosis, they will have better outcome as well. Patient presenting with stroke, 20 to 25% of patients are stroke mimics, where they don't turn out to be stroke after investigation. And diagnosis is usually done by thorough history examination and also with the aid of imaging. Imaging only is not always very sensitive and specific. So it has to be the combination of good history, examination and imaging, which usually helps to differentiate from stroke to stroke mimic. So if we look at the causes of stroke mimics, where they present like stroke but they are not stroke, on the top of the list I have put hypoglycemia intentionally, as hypoglycemia, although is not a common cause, but obviously it's a reversible condition and we should not miss, which can potentially kill people as well. So although hypoglycemia is a generalized disorder, and though they usually present in with general symptom, sometimes hypoglycemia can present with focal deficit, and that's where it can mimic like stroke. Any patient who is presenting with stroke, it's always a rule to check the blood sugar, more so if they are diabetic. So and that's the easiest way to differentiate. Now remember, history is important. Sometimes when we are seeing the patient in A&E, they might be treated for hypoglycemia, and the history is important as well. For example, once we saw a patient who was brought in by the A&E group. So they brought her as first positive, and the patient had sudden onset right-sided weakness, problem with speech. That was what we were told. We took a quick history, and because she was not able to speak clearly, the ambulance crew mentioned about the sudden onset, but they didn't say that patient was hypoglycemic, and they gave some glucose drink to help with the symptoms. So afterward, we understood, although the A&E crew didn't give the handover, we realized the patient was hypoglycemic, and it turned out to be a stroke mimics due to hypoglycemia. So history is important, and when we did the blood sugar in A&E, at that time it was normal, but still patient had symptom. Now remember, one of the important thing is, sometime even if you correct the hypoglycemia, the symptom doesn't go away very rapidly. It may take some time. So the patient came, the blood sugar when we examined was normal. The handover was not very clear that the patient had a hypoglycemic episode. So by the time we took the patient to the CT scanner, she started getting her speech back and her movement back, and she clearly told that she was hypoglycemic. She was working in Tesco Tilt, and then she developed the symptom. She is a known diabetic, and she was treated for hypoglycemia. However, her speech and the weakness persisted. That's why she was brought to hospital, and subsequently she completely recovered. So hypoglycemia could be a presentation for stroke. Post-epileptic Todd's palsy, this is perhaps the commonest, one of the commonest cause of stroke. Following seizures, you get some focal neurodeficit, and that's not uncommon. Obviously, sometimes it is very clear cut. There is a witness seizures followed by weakness, and the patient is a known epileptic. Then it is quite clear cut. But sometimes patient seizures might be unwitnessed. And the other thing to remember, sometimes stroke can be associated with seizures as well. So you have to be very careful to, just because the patient had seizures and has got weakness, we shouldn't jump always to a diagnosis of post-epileptic Todd's palsy as well, because patient can have a stroke and then develop seizures. So the history, if it is not very clear, then always we should be careful in diagnosis. But it is a common cause of stroke mimics. The next is quite common cause is migraine. Obviously, history is key. Usually they are associated with positive symptom like visual aura, paresthesia, and the symptom of the aura usually precede the neurodeficit, and patient usually have headache along with that. Sometimes patient can have migraine without headaches, which is called the acephalic migraine, and they can have aura followed by weakness or sensory impairment or speech problem, etc. So again, history is very, very key. The other important cause of stroke mimic, it could be a stroke mimic and chameleon as well. When we discuss chameleon, we'll come to that. Delirium can be mimicked as a stroke, because the patient, it might appear the patient is dysphasic. It is very important to understand most of the patients who are dysphasic, they usually show other focal neurodeficit like facial droop, associated weakness of the limb. That is very, very important. Where in doubt, obviously investigations like MRI with DWI can help. The other stroke mimics could be brain tumor, especially normally brain tumor, their symptoms are slowly progressive, whereas sometimes patient can have a bleed in the tumor, or the tumor itself can press on the blood vessels due to edema and give sudden presentation like stroke. So obviously careful history and investigation helps to rule it out. The other important cause of stroke mimic is encephalitis, where the patient can have focal neurodeficit along with seizure is very, very common along with encephalitis, and there might be headache as well. So usually the presentation can be acute and it can mimic like stroke. Obviously LP could help to differentiate where there is diagnostic doubt. For example, if the patient is having headache, if the patient is drowsy, and if it is not fitting with one particular vascular territory, encephalitis should always be thought. Now it is important to remember meningitis don't present like stroke because they only can have headache, neck stiffness, though they don't usually have associated neurodeficit until unless it's meningoencephalitis. MS, acute presentation of multiple sclerosis could be a cause of the stroke mimics. Obviously history is very, very important, and sometimes if it is the first presentation, that can be a bit confusing, but usually MRI is quite useful in differentiating acute stroke to multiple sclerosis. The other important cause is highlighting of the old stroke due to metabolic abnormality or sepsis. So for example, patient had a previous stroke, they recover, and then subsequent insult to the body or stress in the body, either in form of metabolic abnormality or sepsis, can bring back the old symptom or highlight the old symptom which the patient previously recovered. And as we all know, the recovery from stroke happens due to neuroplasticity, and any sort of metabolic stress can halt this neuroplasticity temporarily, and if we treat the underlying cause, usually patient get better. Last but not the least, functional disorder, where there is no organic cause which we can find out, but they present like stroke, and extensive investigation and clinical, and there are certain clinical signs which I will discuss in a separate presentation, which can help to differentiate between functional disorder with acute stroke. It is not an uncommon disorder. Around 8 to 9% of stroke are functional, so it is important to remember. At the same time, it is important not to consider at your level functional disorder without ruling out an organic cause. So next important topic is the chameleon. As we said, imitate other disease due to the tempo of onset. Stroke, as we know, is a sudden onset, usually a focal neurodeficit, and there is usually vascular in origin. So in other words, there is vascular risk factor, and The symptom either is permanent or lasting longer than 24 hours, or there is other evidence of damage of the neuronal tissue, i.e., for example, MRI with DWI showing acute infarct. So that's the here in chameleon, their tempo of onset is different. That's why they are commonly missed, although they are stroke, and so symptom don't imitate a particular arterial territory. So they are usually fast negative, like face, all of you know the fast campaign, where you get the facial weakness, arm weakness, speech abnormality, and that's where when we suspect. So atypical presentation, which can cause confusion and be a cause for stroke chameleon, include patient presenting with stroke with movement disorder like acute hemivalismus, dyskinesias, etc. For example, subthalamic stroke or sometimes basal ganglion stroke can have movement disorder, which can be confusing because it's like a positive symptom. They are not common symptom for stroke, and the diagnosis can be missed. Isolated confusion without any other focal neurodeficit, for example, parietal lobe stroke without motor deficit, can easily be considered as acute confusion and not stroke, and that can be a stroke mimic. Sometimes isolated paresthesias can be a feature of thalamic and parietal cortex parietal stroke, which can be missed as well. Acute amnesia due to involvement of the hippocampus or the memory pathway can give rise to symptoms, which although is not a common symptom of stroke, without proper investigation that could be missed. Last but not the least, also handshaking TIA. For example, patient having critical carotid artery disease where the blood flow on one side of the brain is reduced, they can present like limb shaking and can be misdiagnosed as partial seizures. So the other important thing is vertigo. Most of the vertigo is not due to stroke. Especially vertigo, if somebody is presenting with vertigo, careful neurological examination is very, very important. Thorough neurological examination helps to exclude the common causes of vertigo symptom. Stroke giving rise to vertigo symptom include lateral medullary syndrome, lateral pontine syndrome, inferior cerebellar involvement, and in all of these patients there are positive other focal neurodeficit which helps to differentiate. Monoplegia, isolated monoparesis account for less than 5% of all stroke. It affects arm and mostly MCA territory. Sometimes subcortical deeper can give rise to monoparesis. Remember, monoplegia is normally a peripheral nerve problem, but in certain patients, and it could be due to central cause, and that's why it is missed. Delirium could be a presentation for stroke chameleon as well. So as I've mentioned, delirium could be either way. They could be missed, they could be considered as stroke, or they could be stroke mimics, because sometimes the patient can appear as dysphasic, whereas delirium could be missed and could be stroke chameleon, especially involvement of the non-dominant anterior circulation involving the parietal lobe, temporal lobe can give rise to delirium, like delirium, which could be could be, or the stroke diagnosis we missed there. The other atypical type of stroke which could be missed, like persistent acute global amnesia due to bilateral thalamic stroke. Limb shaking TIA, as I mentioned, could be missed as focal epilepsy. Critical carotid artery stenosis, that could be that could present more like a brain tumor like glioma. Cortical stroke, which can present like peripheral nerve lesion, as I said, isolated monoplasia. Bilateral occipital stroke can sometimes present with delirium and confusion, as sometimes parietal or temporal lobe can present with delirium as well. And capsular wounding syndrome, which is where there is blockage, partial blockage of the lacunar arteries, and they could be misdiagnosed as seizures or functional disorder. Capsular wounding syndrome, where you have got a lacunar artery which is partially blocked and they get symptom which can improve, and it can happen multiple times, and sometimes patient get complete occlusion of this lacunar artery, giving rise to full stroke symptom. So early diagnosis and starting secondary prevention can obviously make a difference. So in short, this is about acute delirium, and so this is about stroke mimics and stroke chameleon. Thank you very much.